Welcome to the AOTA webcast, Preparing for ICD-10 Implementation, 2nd edition. The purpose of this presentation is to provide you with information to help you with the transition from ICD-9 to ICD-10 and with ICD-10 implementation within all age groups. This webcast has been created in collaboration with Genesis Rehab Services. Our webcast will be presented by Sharmila Sandhu, Counsel and Director of Regulatory Affairs for AOTA, Elaine Adams, Director of Regulatory Compliance for Genesis Rehab Services, and Laurie Cecchi, Regional Clinical Director, Genesis Rehab Services. Sharmila Sandhu received her undergraduate degree from Cornell University and her legal degree from the American University Washington College of Law. Following law school, Ms. Sandhu was employed as a healthcare associate, primarily advising hospitals and physician practices at the law firm of Epstein, Becker & Green in Washington, D.C. Ms. Sandhu later gained extensive experience in health policy matters, working with healthcare trade associations, including AOTA, the American Nurses Association, and the American Academy of Audiology, where she advised association members and leadership regarding Medicare coverage, payment, and coding issues. Ms. Sandhu is a member of the District of Columbia Bar Association and the American Health Lawyers Association. Elaine Craddy Adams has been an occupational therapist for over 30 years and has worked in a variety of settings. She is currently employed as Corporate Director of Regulatory Compliance for Genesis Rehab Services. She has a working knowledge of Medicare and other healthcare reimbursement systems, as well as other healthcare-related federal, state, and local issues. She is a member of the Gerontology and the Administration and Management Special Interest sections of AOTA, and she often collaborates with AOTA on regulatory, coding, and reimbursement issues. Laurie Cecchi has been an occupational therapist for 26 years, the first 18 years of which were spent in school-based and private practice. She transitioned to Genesis Rehab Services in 2008 in a variety of positions, initially as a staff therapist, then program manager, clinical specialist, and now as a regional clinical director with specialties in dementia management and managing behaviors. We would also like to take this opportunity to thank several people who collaborated and contributed to this presentation. These people include Joanne Wisely, Heather Pazak, and Susan Daradine from Genesis Rehab Services, Tara J. Glennon from the Center for Pediatric Therapy in Fairfield and Wallingford, Connecticut, and Quinnipiac University, and Susan Guzowski from Yale New Haven Hospital. I will now turn the presentation over to Sharmila, who will provide a session overview and an overview of ICD-10 transition.
Thank you, Debbie. For this presentation, we will start by providing some legislative and regulatory background information about ICD-9 to ICD-10 transition, and then review some coding basics. Next, we will review basic information about ICD-10 and spend some time discussing how to choose and document ICD-10 codes. We will wrap up with a section that focuses on considerations for managing ICD-10 implementation. Before we launch into the new content of the presentation, let's review a few logistics regarding this continuing education podcast. First, you will find intermittent slides that allow you to assess your learning as the presentation proceeds. Additionally, throughout this presentation, you will see links to various resources. These links have been compiled into a handout that you may save electronically and use to access the various web pages. Upon completion of this session, to earn continuing education units, you will be required to complete a test. After confirmation of a passing score, you will be able to print a certificate to verify that you have completed the course. Links to the handout and the test are provided as part of this learning module. As you can see, there are several learning objectives for this session. By the end of the session, it is expected that participants will be able to Describe the differences between ICD-9 codes and ICD-10 codes. Explain the structural components of ICD-10 codes. Explain clinical, regulatory, and billing considerations that influence the selection of diagnosis, condition, and complexity codes. Discuss elements of documentation essential to the support of ICD-10 coding. Identify important considerations for facilitating and managing ICD-10 implementation. Now I turn to the slide on legislative and regulatory background. The World Health Organization, which focuses on international health and outbreaks, began work on the 10th edition of the International Classification of Diseases, or ICD-10, coding system nearly 30 years ago in 1983. They didn't actually finish until 1992, nearly a decade later. Many other nations across the world adopted ICD-10 before the United States. However, political interest dominated in delaying the implementation of ICD-10 in the U.S. In August 2008, the Department of Health and Human Services proposed that medical professionals use ICD-10 for reporting diagnoses and procedures on healthcare transactions in the U.S. On January 15, 2009, the U.S. Department of Health and Human Services published a final rule establishing ICD-10 as a new national coding standard with an implementation date of October 1, 2013. Then, through various legislative and regulatory acts, 2013 became 2014. And then, just when we thought that ICD-10 had finally broken through the bureaucratic red tape and the extensions were over, 2014 became 2015. On March 31, 2014, H.R. 4302 enacted a one-year fix of the sustainable growth rate formula, and that law also included a one-year extension of ICD-10 to the date of October 1, 2015. Although advocacy by AMA and other groups continued, the date of October 1, 2015 remained the effective transition date for ICD-10 and was implemented several months ago on October 1st, 2015. The medical codes America uses for diagnoses and billing have not been updated in more than 35 years prior to that date and contained outdated, obsolete terms. Moving to the next slide on legislative and regulatory background. On July 6, 2015, AMA and CMS announced efforts to ease the transition to ICD-10 for providers. For 12 months, Medicare claims would not be denied if providers used the wrong code as long as the code is in the right family of codes. It is important to note that this allowance was aimed at certain providers, such as those who bill Medicare as individual professionals, as opposed to facility-based providers. Free resources, including the Road to 10, aimed at smaller physician practices, are available on the CMS website. In addition, the AOTA has a dedicated ICD-10 webpage on its website. In addition, a new ICD-10 ombudsman was appointed to answer questions about claim submission and ICD-10 issues. Additional details can be found using the links on the screen. In addition, it is important to note that October 1st, 2015 implementation date is mandated for HIPAA transmitting healthcare providers or covered entities. It is worth noting that to use both ICD-9 and ICD-10 to accommodate their payer mix. For example, typically workers' compensation providers are non-HIPAA transmitting entities. The documents noted on the slide provide more information about covered providers and entities. These links have also been provided in the handout. So why change the ICD-10 codes? There's much greater specificity and clinical information in the ICD-10 coding, and that results in a number of positive benefits, including improved ability to measure healthcare services, updated medical terminology and classification of diseases, and better data for a number of different aspects, including measuring care furnished to patients, designing payment systems, for processing claims, for making clinical decisions, tracking public health, identifying fraud and abuse, and for conducting research. These benefits are in contrast to the drawbacks of the previous ICD-9 system. Some of those drawbacks include that the system did not provide the necessary detail for patients' medical conditions or the procedures and services performed on hospitalized patients. ICD-9 was over 34 years old. It used outdated and obsolete terminology, and it used outdated codes that produced inaccuracies and limited data. And it was inconsistent with current medical practice. It could not accurately describe the diagnoses and inpatient procedures of care being delivered in the 21st century. Here is your first Assess Your Learning slide. Read the question and select the best answer. We will then proceed to the next slide to check the answer. The correct answer is B, October 1st, 2015.
Hello. Before we get into the specifics about ICD-10 coding, let's consider the purposes of coding. Coding paints a picture of the client and the services received using a language of codes on a claim. It provides a means by which electronic editing can be used to process claims, as well as to identify claim errors or issues. Coding also facilitates data collection, data mining, and data analysis. These purposes show the importance of ensuring that clinical and billing documentation support each other. The International Classification of Diseases, referred to as ICD, is a coding system used to identify, classify, and code client diagnoses, conditions, and complexities, hospital procedures, and mortality data from death certificates. ICD-9 codes have been in use in the United States for many years and have typically been updated on an annual basis. The updates, which include new, revised, and deleted codes, have typically been released in the summer for implementation on October 1st. Annual files back to 1996 are available at the link on the screen. The International Classification of Diseases 9th Revision Clinical Modification, known as ICD-9-CM, is currently in use in the United States, but as noted previously, transition to the International Classification of Diseases 10th Revision system is set to occur on October 1st, 2015. In preparation for the transition, in recent years, there have been limited updates to ICD-9 codes. ICD-10 codes are copyrighted and developed by the World Health Organization. ICD-9-CM and ICD-10 code changes and modifications for the United States are overseen by the Centers for Medicare and Medicaid Services and the National Center for Health Statistics. Here is another Assess Your Learning slide. Again, read the question and select the best answer. We will then proceed to the next slide to check the answer. The answer is D, A and B above. Therapy services, on the other hand, are typically coded using current procedural terminology codes, referred to as CPT codes, which are part of the Healthcare Common Procedure Coding System, referred to as HCPCS codes. When coding, accuracy is paramount for several reasons. Accurate and thorough coding is needed first and foremost to clearly identify and communicate the conditions and problems that need to be addressed in the plan of care for occupational therapy. This information is important for those providing care, as well as for those doing the billing for the OT services, or those reviewing the medical record. Accurate coding is also necessary to decrease the risk of claim errors. When there are errors on claims, the claim may be rejected or returned to the provider, referred to by billers as an RTP claim. Errors require claim corrections and can lead to billing inefficiencies due to the time needed to investigate and correct an error. Claim errors can also lead to delayed or denied payment for OT services. Further, a pattern of claim errors may target a provider for medical review to make certain that payment is appropriate and to facilitate education and correction of errors. Additionally, payers expect that coding will align with coverage policies by those payers, and regulations such as those for Medicare and Medicaid require accurate and complete billing information. Let's take a few minutes now to review some diagnosis coding basics. As part of an evaluation, occupational therapists are expected to document a primary diagnosis. Per a definition provided by the Centers for Medicare and Medicaid Services, the primary diagnosis is the pertinent written medical diagnosis resulting in the therapy disorder and relating to 50% or more of the effort in the plan of treatment. This diagnosis is typically obtained from the referring physician or non-physician practitioner, such as a nurse practitioner or physician assistant. Occupational therapists usually determine the treatment diagnosis or diagnoses. The Centers for Medicare and Medicaid Services note that the treatment diagnosis is the written treatment diagnosis for which services are rendered. It is based on evaluation findings. To determine the treatment diagnosis or diagnoses, it is important and helpful to use a clinical reasoning approach. For instance, if upon evaluation it is found that a client requires maximal assistance with upper extremity dressing, fill in the sentence, "The client requires maximal assistance with upper body dressing because." Once identified, the reason for the functional difficulty can be translated into an ICD code. Consider, for example, when the reason is lack of coordination. The ICD-9 code might then be 781.3. For ICD-10, the code might be R27.0 for ataxia unspecified, R27.8 for other lack of coordination, or R27.9 for unspecified lack of coordination. When coding accurately and thoroughly, it is important to also document any pertinent secondary diagnoses or comorbidities. A secondary diagnosis or comorbidity is a condition that may influence recovery from the primary diagnosis. The condition can be old, chronic, or new. When painting the picture of a client, secondary diagnoses and comorbidities help to present a clearer picture of the client's circumstances. For example, consider two clients recovering from a hip replacement surgery. A client with a comorbidity of Parkinson's disease will present quite differently from a client without a neurological condition. Similarly, a client with comorbidities of low vision and severe depression will present differently than one without those comorbidities. To code accurately, when determining a client's diagnoses, conditions, and complexities, it is important to code to the most specific degree. From this perspective, it is best whenever possible to avoid codes with vague descriptors such as codes that include the word unspecified. As noted on previous slides, it is essential to include pertinent comorbidities and to ensure that clinical documentation supports the coding. Here's another Assess Your Learning slide. Again, read the question and select the best answer. Please take a moment to consider why you selected that answer, and then we will proceed to the next slide to check the answer. The answer is false. There are several reasons to code accurately. First and foremost, to clearly identify and communicate the conditions and problems that need to be addressed in the plan of care for occupational therapy. It is also important to become familiar with payer coverage criteria, policies, and coding guidance, a topic we will touch further on in the next few slides. Depending on where you work, there may be other factors to consider when choosing and/or reporting codes. During the transition from ICD-9 to ICD-10, especially with the primary diagnoses, it will be important to ensure that you are clear on who is assigning the codes and where they are recorded. Again, depending on your work setting as well as your payer mix, it is essential to know what information is needed and/or allowed for the particular billing form, whether a paper form or an electronic form. For example, does the form have a limited number of fields to record ICD codes? Lastly, but certainly not least, it is imperative that you know and comply with your scope of practice and any Practice Act specifications regarding referrals and assignment of diagnoses. Before we move on to take a closer look at ICD-10 codes, a further word about payer policies, in particular, Medicare payer policies. The Centers for Medicare and Medicaid Services, frequently referred to as CMS, provides payer policies by two means. The first is National Coverage Determinations, or NCDs. NCDs provide guidance for nationally applied coverage specifications for an item or service. Examples of NCD topics include electrotherapy for treatment of facial nerve palsy, Bell's palsy, and transcutaneous electrical nerve stimulation, TENS. A link to the NCD manual is included in the handout. The second type of coverage policy from CMS is Local Coverage Determinations, or LCDs. Laws and regulation allow for Medicare Administrative Contractors, or MACs, to provide localized coverage guidance. MACs are entities that process Medicare claims for designated geographic areas. LCDs typically include guidance for use of HCPCS or CPT codes, which are the service codes used to identify therapy interventions. They also commonly include guidance for non-covered services. LCDs very often include specification of ICD codes that are considered to support medical necessity of therapy services, sometimes as a general list, and sometimes specifically for various HCPCS or CPT codes. If a service is billed without a supporting ICD code, that claim may be rejected, returned to the provider, or denied. Many of the MACs have published future versions of LCDs to provide ICD-10 specifications. As with NCDs, links to LCD resources are provided in the handout. The LCDs, current and future, may be found on MAC websites or in the CMS coverage database. Here is another Assess Your Learning slide. Again, read the question and select the best answer. We will then proceed to the next slide to check the answer. The untrue statement is B. As noted in the previous slides, payers may provide policies, coverage criteria, and/or guidance regarding the types of conditions and complexities that support the necessity of therapy services. The ICD code must be supported by the documented medical history and evaluation findings and must relate to the OT plan of care. Let's take a closer look now at ICD-10 codes, starting with a comparison of ICD-9 and ICD-10. There are several similarities. Both are coding systems used to identify client diagnoses, conditions, and complexities. They also use a similar method for code choice. Additionally, it is expected with both systems that healthcare professionals will code to the most specific degree and that documentation will support coding. Both systems require that codes have at least 3 characters with a decimal point after the third character. And for both the ICD-9 and the ICD-10 system, codes are considered to be invalid if a character is missing. In regard to differences, there is a difference in the number of codes. There are approximately 14,500 ICD-9 CM codes. However, for ICD-10 CM, there are approximately 69,000 codes. The ICD-10 system additionally includes ICD-10 PC codes, which are procedure classifications used in inpatient hospital settings. A significant difference is in the code specificity. The ICD-9 CM coding system is a medically focused coding system. It has more general and vague classifications and has limited space for new codes. The ICD-10 CM system has greater granularity with additional coding options and requirements, such as specification of laterality, characteristics, and/or sequence of intervention. Injuries are organized first by anatomical classifications as opposed to being primarily organized by type of injury. The ICD-10 system allows for flexibility for additional codes. Procedure classification codes have a separate organization methodology that will not be covered in this podcast. There is also a difference in the code structure. ICD-9 CM codes are 3 to 5 characters in length and may be preceded by E or V, but are mostly all numeric. ICD-10 CM codes are alphanumeric codes that are 3 to 7 characters in length. PC codes are 7 characters in length. This slide shows the structure of an ICD-9 CM code. The first character may be an alpha character, E or V, or a numeric character that represents a diagnostic or condition category. The second and third characters are numeric characters and again represent a diagnostic or condition category. If the code has a fourth character, it is a numeric character meant to represent specificity within a category. If a code has a fifth character, it will also be a numeric character and is meant to provide additional details such as location, joint, origin, or characteristics of the problem. Consider the example on the slide. The first, second, and third characters, 4 through 8, represent late effects of cerebral vascular disease. The fourth character, a 2, represents hemiplegia or hemiparesis. The fifth character, 1, means affecting dominant side. This slide shows the structure of an ICD-10 CM code. The first character specifies the code category and is an alpha character. The ICD-10 system uses all letters except U. The second character and third character are also representative of a code category. However, the second character is always numeric, while the third character may be an alpha or numeric character. If a code has a fourth, fifth, and/or sixth character, the character may be an alpha or numeric character and will represent a code category, an anatomical site, or a severity description. When a code requires a seventh character, it is considered to be an extension character and may also be an alpha or numeric character. A seventh character is used when required to specify an encounter sequence, external cause, or other specification. Consider this ICD-10 example. The first character is an alpha character, I, which represents diseases of the circulatory system. As you can see, the second character is a numeric character, and the third is also a numeric character. Together, the first 3 characters, I, 6, 9, represent sequela of cerebrovascular diseases. The fourth character is a numeric character, 8, representing sequelae of cerebrovascular diseases. The fifth character, also in this case numeric, represents hemiplegia and hemiparesis following other cerebrovascular disease. The sixth character, again in this case a numeric character, a 1, means affecting right dominant side. The seventh character does not apply for this ICD-10 code as there is no note to add a seventh character. This slide shows a side-by-side comparison of the ICD-9 CM code and ICD-10 CM code examples just discussed. You can see that the ICD-9 code is 5 characters, while the ICD-10 code is 6 characters, with the first character being a letter. The ICD-9 code descriptor is a bit shorter and less specific than the ICD-10 code. The ICD-10 code specifies the laterality for the dominant side. As with other Assess Your Learning slides, read the question and select the best answer. We will then proceed to the next slide to check the answer. The untrue statement is C. ICD-10 CM codes are alphanumeric codes, but they are 3 to 7 characters in length. As previously noted, the seventh character is considered to be an extension character. The meaning of the seventh character is dependent on the section or chapter of the ICD-10 tabular list. Take a few minutes to look at the list of instances noted on the slide where a seventh character may be required. In regard to the type of encounter, there are 3 terms you will see in the seventh character coding options. They are for an initial encounter, subsequent encounter, and sequela. The initial encounter code is for the initial active treatment. The subsequent encounter is typically for aftercare, and the sequela for intervention because of complications or conditions that arise. For more information, see slide 27 in the resource noted on the slide. This slide provides an example of a code that requires a seventh character. In this case, the condition is a stress fracture of the left hand, with the seventh character representing a subsequent encounter for fracture with routine healing. As noted previously, and as you can see from the examples, the degree of specificity is a major difference between ICD-9 and ICD-10 codes. As you can see from descriptors on the screen, greater specificity is achieved through descriptors that include laterality, such as right, left, bilateral, unilateral, both, or dominance. Specific locations such as upper back, middle finger, radial carpal ligament. Acuity, such as acute, spontaneous, chronic, exacerbation, persistent, or intermittent. And severity, such as complicated, simple, uncomplicated, displaced, non-displaced, the stage, or intractable. You may have heard of some of the external cause codes such as contact with a cow or activities involving roller coasters and other types of external motion, and you may have wondered why such detail and coding is needed. The greater degree of granularity can at first seem overwhelming. However, there are reasons for the increased specificity. It allows for more detailed data collection and analysis, especially for those occurrences or conditions that may be more common in one geographic area as opposed to another. It allows for more detailed data mining for research. It can also help in identifying the responsible payer. For example, a code that includes an injury that was the result of an automobile collision may point to a motor vehicle insurance being the primary payer. If you are interested in gaining more perspective on this issue, there are many articles that provide perspectives on the specificity of ICD-10 codes. A couple of these articles are listed on the slide and included in the handout. I would like to take a few minutes to take a look at a set of codes of particular interest to occupational therapy practitioners, that of codes related to low vision. With the ICD-9 CM system, there are multiple codes specified by total, near total, profound, severe, moderate, unqualified vision loss, and legal blindness. With the ICD-10 CM system, there are fewer codes and the specifications are blindness, low vision, unqualified vision loss, and legal blindness, with numeric categories of impairment, 1 to 5 and 9. Categories 1 to 2 are for low vision. Categories 3 to 5 are for blindness, with 5 indicating no light perception. And Category 9 is noted as undetermined or unspecified. Here is another Assess Your Learning slide. Again, read the question and select the best answer. We will then proceed to the next slide to check the answer. The answer is D, one or more of the above. Increased specificity may be seen in descriptors that include laterality, acuity, or severity, and also specific locations of a problem. A few additional notations about external cause codes. These codes, found in chapters 19 and 20 of the Tabular Index, are meant for data collection for injury research and prevention. There is currently no national mandate for use, but they may be required by states or particular payers, and voluntary reporting by providers is encouraged. I would like to take a few minutes to look at a set of codes of particular interest to occupational therapy practitioners, that of codes related to low vision. With the ICD-9 CM system, there are multiple codes specified by total, near total, profound, severe, moderate, unqualified vision loss, legal blindness. With the ICD-10 CM system, there are fewer codes and the specifications are blindness, low vision, unqualified vision loss, and legal blindness with numeric categories of impairment, 1 to 5 and 9. Categories 1 to 2 are for low vision, categories 3 to 5 are for blindness, with 5 indicating no light perception, and category 9 is noted as undetermined or unspecified. Here is another Assess Your Learning slide. Again, read the question and select the best answer. We will then proceed to the next slide to check the answer. The answer is D, one or more of the above. Increased specificity may be seen in descriptors that include laterality, acuity, or severity, and also specific locations of a problem or injury. Another significant note about ICD-10 is in regard to font. Because there are the letter O and the number 0, as well as the letter I and number 1, the font needs to visually distinguish the differences. As you can see in the examples on the screen showing the ICD-10 code for non-traumatic subarachnoid hemorrhage from right middle cerebral artery, the Consolis font helps to distinguish similarly shaped letters and numbers. The convention for ICD-10 is to use a /0 to distinguish 0 from the letter O. Use of a font with the letter I that has a horizontal top and bottom line is used to avoid being confused with the number 1. Another nuance of ICD-10 codes is what is referred to as an X placeholder. The X placeholder is used in the 5th or 6th character position to allow for future code expansion while maintaining ICD-10 code structure. Also of note in regard to font, alpha characters are not case sensitive. In regard to coding conventions, ICD-10 coding guidance provides information about other coding considerations when choosing codes. This guidance is updated annually. Fiscal year 2016 guidance can be found at the link on the slide, which is also included in the handout. Such guidance is also provided in most ICD-10 manuals. Once again, an Assess Your Learning slide. Read the question and select the best answer. Please take a moment to consider why you selected that answer, and then we will proceed to the next slide to check the answer. The answer is false. Even with the increased specificity of ICD-10 codes, the clinical documentation must still support the chosen codes. Let's now talk about looking up and choosing ICD-10 codes. It may be necessary to use both the alphabetic index and tabular lists. The alphabetic index provides an alphabetical listing of the code descriptors. The tabular list organizes the codes by chapter and categories of diseases, illnesses, injuries, and conditions. There are also chapters for external cause codes and a chapter for coding factors that influence health status and contact with health services. The codes you use will be dependent on the settings in which you work and the populations with whom you work. When looking up codes, it may be necessary to work backwards or to use key terms. For example, when looking up congestive heart failure, you will find that it is listed first under failure, then heart, then acute congestive. Further, it is important to pay attention to notations listed with the codes, such as when a 7th character is required or when notes are included about inclusions, exclusions, or default codes. The Centers for Medicare and Medicaid Services has provided online access to the alphabetic index and tabular index. The links are also provided on a subsequent slide and in the handout. To help health professionals with the conversion from ICD-9 to ICD-10 codes, there are several crosswalk resources and tools available. The Centers for Medicare and Medicaid Services has provided general equivalence mappings called GEMS. Crosswalks also are available from various vendors and organizations. It is essential to use the crosswalks with caution, as they are meant as a guide or tool rather than an absolute conversion. It is often not a one-to-one exchange. With most crosswalks, a vague ICD-9 will provide ICD-10 coding options that are vague, while a detailed ICD-9 will point to detailed code choices. It will be important to consider coding options and choose the codes that best and most specifically describe the client's disease, illness, injury, condition, or complexity. It is also necessary to consider coding options and instructions. As noted, there are several resources available to help with mapping ICD-9 to ICD-10 codes. This slide shows some of those resources. As you are using an electronic documentation system, you may even have if you are using an electronic documentation system, you may even have a mapping function built into the system. You will need to determine which tools and resources will work best for you and help you to ensure accurate and complete coding. As you can see on the slide, These resources include the previously mentioned online version of the ICD-10 alphabetic index and tabular list, and the CMS GEMS files, as well as the Centers for Disease Control and Prevention ICD-10 webpage, and various websites that provide crosswalk tools such as the AAPC, ICD-10 data, and ICD-9 data websites. In the next several slides, we will review some examples of ICD-9 to ICD-10 conversions using a few different mapping resources. Before we do so, I would like to note here that neither AOTA or the speakers for this educational session are advocating use of any particular ICD-9 to ICD-10 mapping tools or resources. The examples provided here are meant to illustrate the types of information provided, tools and resources, and to emphasize that due to the variety of resources available, that it will be necessary for healthcare professionals to determine which tools and resources they may use. Now Laurie will review some examples of ICD-9 to ICD-10 conversions.
One, two. The next several slides will provide examples of several diagnoses, conditions, and complexities, some of which may be used with adults or children, some of which are more commonly used with adults, and some of which are more commonly used with children and adolescents. This first slide shows the conversions using the CMS GEMS files. The GEMS conversion file shows ICD-9 and ICD-10 codes, but does not show the descriptors with the codes. As you can see, 781.0 abnormal involuntary movements may crosswalk to R25.0 abnormal head movements, R25.1 tremor unspecified, R25.2 cramp and spasm, R25.3 fasciculation, R25.9 unspecified abnormal involuntary movements. It would be necessary to choose the code that best describes the client's involuntary movements. I'm sorry, Debbie, you have to pause. The next several slides will provide examples of several diagnoses, conditions, and complexities, some of which may be used with adults or children, some of which are more commonly used with adults, and some of which are more commonly used with children and adolescents. This first slide shows the conversion using the CMS GEMS files. The GEMS conversion file shows ICD-9 and ICD-10 codes, but does not show the descriptors with the codes. As you can see, 781.0 abnormal involuntary movements may crosswalk to R25.0 abnormal head movements, R25.1 tremor unspecified, R25.2 cramp and spasm, R25.3 fasciculation, R25.9 unspecified abnormal involuntary movements. It would be necessary to choose the code that best describes the client's involuntary movements. This slide shows another conversion using the CMS GEMS files. With this example, ICD-9 code 331.83, impairment, cognitive, mild, may crosswalk to ICD-10 code G31.84, mild cognitive impairment, so stated. This slide shows mapping results for a couple of ICD-9 codes using the AAPC webpage noted on the screen, which is a resource commonly referenced by professional coders. As you can see, ICD-9 code 784.60 symbolic dysfunction, unspecified, may crosswalk to ICD-10 code R48.9, unspecified symbolic dysfunctions. ICD-9 code 784.69, other symbolic dysfunction, acalcula, agnosia, agraphia, not otherwise specified, and apraxia may crosswalk to R48.1 agnosia, R48.2 apraxia, and R48.8 other symbolic dysfunctions. Again, you would need to choose the code that best describes the client's condition. Here are a few other examples of conversions using a different mapping resource, the ICD-10 data website noted on the screen. On this slide, you can see that the ICD-9 code 787.21 dysphagia oral phase may crosswalk to an ICD-10 code with an identical descriptor R13.11 dysphagia oral phase. Likewise, ICD-9 code 728.87 weakness, muscle, generalized may crosswalk to an ICD-10 code with a similar descriptor M62.81 muscle weakness, generalized. ICD-10 code 783.3 eating difficulties and mismanagement may crosswalk to R63.3 eating difficulties, and ICD-9 code 343.0 congenital diplegia may crosswalk to ICD-10 code G80.1 spastic diplegic cerebral palsy. This website provides many code hyperlinks to assist with exploration of coding options. I would like to again note that neither AOTA or speakers for this education webcast are advocating the use of any particular ICD-9 to ICD-10 mapping tools or resources. The examples provided here were meant to illustrate types of information provided by mapping tools and resources, and to emphasize that due to the variety of resources available, that it will be necessary for healthcare professionals to determine which tools and resources they may use. This slide shows ICD-10 coding options for Alzheimer's disease, found when looking in the CMS online tabular list. I started by choosing a relevant chapter, Diseases of the Nervous System. Then I chose the section regarding other degenerative diseases of the nervous system and scrolled to locate the descriptors related to Alzheimer's disease. As with other examples, there are a few options. With this medical diagnosis, the OT would need to determine, based on the medical record documentation and possibly collaboration with medical encoding personnel, which code is most appropriate. When looking up options via the alphabetic or tabular index, you may also choose to use a hard copy ICD-10 manual. The next slides show ICD-10 coding options for pervasive developmental disorders. For this diagnostic group, I started by looking up Asperger's syndrome in the alphabetic index and found the lead characters are F84. I then looked in the tabular index and found that the codes beginning with the letter F in Chapter 5, the chapter titled Mental, Behavioral, and Neurodevelopmental Disorders. As with the prior example, I scrolled through the subsections to locate the section with codes beginning F84. This subsection is titled Pervasive Developmental Disorders. When I clicked on the link to this subsection, I found the coding notations and options listed on this slide and the next few slides. It is essential that providers take note of any guidance provided, such as the notations on the screen about additional codes and exclusions. The coding options in this subsection move from F84.0 to F84.2. In other words, there are currently no F84.1 code. F84.2 is used for Rett syndrome. It is important to pay attention to the notes about exclusions. This This slide shows the next code in the sequence for this subsection, F84.3, Other Childhood Disintegrative Disorder, which includes dementia infantilis, disintegrative psychosis, Heller's syndrome, and symbiotic psychosis. Again, please note the exclusions. Here you can see the rest of the coding options from this subsection, including Asperger's syndrome, other pervasive developmental disorders, and pervasive developmental disorder unspecified. The coding options for attention deficit hyperactivity disorders are also in Chapter 5 in the subsection titled Behavioral and Emotional Disorders with onset usually occurring in childhood and adolescence. Attention deficit hyperactivity disorders codes begin with F90 and, as will be seen on the next slide, require a fourth character to designate the type of ADHD. As you can see here, there are 5 options for ADHD, the first 3 of which provided a more detailed descriptor and the last 2 of which provides a less specific descriptor. As noted previously, it is expected codes with more detailed descriptors will be used whenever possible and supported in clinical documentation. An additional note about coding for attention deficit disorder without hyperactivity. Under ICD-10 CM, the code was designated as 314.00. The ICD-10 CM tabular index included a notation that 314.00 was for attention deficit disorder of the predominantly inattentive type. ICD-9 code 314.00 may therefore crosswalk to ICD-10 F90.0, attention deficit hyperactivity disorder, predominantly inattentive type. You may find with some conditions, such as in the example noted on the slide, that there is not a direct translation for the specific descriptor. In such cases, you may need to choose a more vague code that most closely represents the client's condition. On the other hand, for some conditions, you may find it best to explore several options because there are many options. For instance, there are many options for coding developmental delays and learning problems. Under ICD-9 CM, these codes range from 315.00 to 315.9. Under ICD-10, there are several coding options that begin with the characters F80, F81, and F82. The section descriptions can be seen on the slide. Under each of these sections, there are specific coding options that may require a fourth and/or fifth character. A few examples from the F81 section are provided on the next slide. Here are a few examples of the coding options listed under the section titled Specific Developmental Disorders of Scholastic Skills. Not otherwise specified stands for not otherwise specified. It is important to take note of the inclusions and exclusions. Additionally, a reminder, as with all of the examples provided, the OT will need to choose the code that best represents the client's condition and is supported in the documentation, and will need to consult with other team members as needed. Here is another Assess Your Learning slide. Again, read the question and select the best answer. Please take a moment to consider why you selected that answer, and then we will proceed to the next slide to check the answer. The answer is true. It is important to remember that the mapping tools and resources are meant to guide healthcare practitioners regarding coding options, but the mappings are not always direct one-on-one matches, requiring the practitioner, based on the clinical documentation and findings, to determine the ICD-10 code that best describes the client's conditions. Now Elaine is going to review some important considerations in managing the implementation of ICD-10 coding.
Thank you, Laurie. To facilitate a successful transition to ICD-10 codes, it is essential to look to measures you may take to embrace, facilitate, and continue to manage ICD-10 implementation. An important consideration is coding practices. Continue to take stock of conditions you typically treat and the ICD codes associated with them. Look at diagnosis coding specifications and requirements for setting specific assessments, care planning, and reporting tools, such as the skilled nursing facility minimum data set, the home health outcome and assessment information set, and the inpatient rehabilitation facility patient assessment instrument. Routinely check or refer to payer policies, coverage criteria, and guidance. Continue to assess coding resources, including those used, available, and/or needed. These resources may include persons, electronic resources, and/or hard copy resources. Because OT is practiced in so many different types of settings, with so many different types of populations, it is difficult to provide a global tool that hones in on an OT subset of codes. OT practitioners therefore need to determine the types of resources that would work best for them for the settings and populations they serve. The next consideration is documentation processes and content. As you think about this important professional responsibility, keep in mind that in recent years, as healthcare reform has unfolded in the United States, efforts to coordinate services across the spectrum of care have become a focus. Accurate and thorough documentation and standard terminology play a key role in effective communication between healthcare providers. On a routine basis, check your evaluation, clinical notes, and billing log forms and format. Assess outcome measure instruments currently used and available for use. Analyze how you currently document to support codes. Determine gaps and identify where changes are needed to support the increased specificity of ICD-10. For example, as noted in previous slides, laterality, severity, dominance, the visit sequence, the acuity of a client's condition. Assess the need for process and resource changes and updates, and safety nets, such as prompts for mandatory completion of certain electronic data fields, warnings for incomplete fields, or the addition of headings to hard copy forms. Be sure to document clearly and thoroughly, capturing necessary details to support ICD-10 codes. As has been noted, clinical documentation must support coding. However, to support the increased specificity of ICD-10 codes, greater detail may be needed in the documentation. It is therefore important to check medical and/or educational records for supportive documents. For example, check the history and physical, admission documents, specialist reports, physician orders, and with children, if applicable, check the Individualized Education Program or IEP. Consult with the physician or non-physician practitioner as needed to ensure diagnoses, conditions, and complexities are clearly identified and documented. Also, when needed, consult with other personnel involved in coding, such as a medical record staff person, the health information management staff, the MDS coordinator, billing staff, or team members. A few additional notes about documenting to support coding. It is important to ensure evaluation entries and data support the medical and treatment diagnoses chosen. Use a clinical reasoning approach when selecting and documenting codes. Be sure to document code additions, changes, and updates as indicated, For example, as needed when doing a reevaluation, a recertification, or progress reports. Document clearly and thoroughly, capturing necessary details. Use ICD-10 terminology when appropriate, as it will help to show a match with the chosen code or codes. It is important to remember, regardless of setting, that your documentation, including your coding, is a communication tool. Thus, it is essential that your documentation and coding be accurate and thorough. Another consideration for management of ICD-10 implementation is billing and coding, especially if you are in an administrative or management position. It will be important to continue to collaborate with your billing staff regarding such issues as billing form requirements and limitations, duties and responsibilities, and communication processes related to coding and claim submission, issue resolution processes, and any payer exemptions that may require continued use of ICD-9 CM codes. Education and resources are yet another essential consideration as you manage ICD-10 implementation. It will be important to continue to assess coding education needs, to continue to tap into available resources such as those listed on the slide, and to continue to update your education plan as needed. If you work in private practice, you may find it helpful to use some of the resources listed in the handout. If you work for a facility or agency, it will be important to find out what educational updates are being offered and to be sure to participate in the education provided. If you are in an administrative or management position and charged with developing additional education, you may find again that the resources in the handout will be helpful. The list includes several training resources from the Centers for Medicare and Medicaid Services. It is additionally important to assure that you continue to consider communication and reporting related to ICD-10 coding on a routine basis, analyze the flow of coding information, and examine support systems. For example, do therapist codes automatically flow to the billing office through an electronic interface, or do reports need to be compiled and handed off at particular points in the week or month? If a code is found to be incomplete, how is the therapist alerted? Determine where changes or updates are required and develop a timeline for testing and implementation. By taking time to do such analysis and ensure that systems are effectively working, you can help to assure that any issues with ICD-10 implementation are addressed in an appropriate and timely manner. Here is your last Assess Your Learning slide. Read the question and select the best answer. As with other Assess Your Learning slides, we will then proceed to the next slide to check your answer. The answer is D. As you implement the transition from ICD-9 to ICD-10 codes, there are several important considerations. Those steps include items A through C. While it is important to assure that clinical documentation supports ICD-10 coding, the transition to ICD-10 coding is not expected to impact clinical practice and decision making. Just a couple of other considerations before we wrap up this podcast. Monitoring and quality improvement and quality assurance, known as QI/QA, are of paramount importance, particularly so with new processes. Such a process will help to assure that coding is appropriate, accurate, and complete. If you are in an administrative or management position, you may be expected to establish or oversee QI/QA processes. With the transition to ICD-10 coding, it will be important to implement a routine audit process that looks at codes used and assesses whether documentation supports coding. The next step would be to establish and implement a QI/QA process to address concerns noted and to assure ongoing quality. A typical QI/QA plan includes documentation of the problem, actions to be taken, responsible parties, a timeline, and a plan for ongoing monitoring. Lastly, it will be important to stay current. You can do so by signing up for the CMS, MAC, or payer notices or listservs. You may also find it helpful to connect with specialty societies and special interest groups, and to monitor key websites such as the CMS, AOTA, CDC, Medicare contractor, and payer websites. This slide shows additional resources that you may find to be helpful as you manage the transition to ICD-10 codes, including resources noted on the previous slide. These websites and links to specific web pages and tools and some references are listed on the handout. Questions or requests for more information may be sent to regulatory@aota.org. Thank you for viewing and listening to this webcast. We hope that the presentation has helped you to increase your knowledge regarding ICD-10 codes and provided you with helpful information for embracing, facilitating, and managing ICD-10 implementation.